The next topic, Dr. Jeffrey Ralph is going to be talking about current treatment options for peripheral neuropathy. Dr. Ralph is an associate clinical professor at UC San Francisco and a practicing neurologist. He is the director of the Neuropathy Center at UCSF Medical Center. Dr. Ralph attended the University of North Carolina at Chapel Hill School of Medicine. He completed a neurology residency and fellowships in neuromuscular and clinical neurophysiology at the University of California, San Francisco. Welcome, Dr. Ralph.
Do you need to upload a new file?
Oh, you do?
Yeah.
Okay.
Let's see. Hello, everyone. I can't believe this is the 11th anniversary of this event. I had brown hair beginning. Dominic still has brown hair. It's easier to follow Dr. Lewis and the hunky fitness person that you'll see in the afternoon. No, you're hunky too. Okay, so let's see. I think it's not in all the way. There we are. Okay, good. All right. Okay, not my tax return, but that. Okay. Okay, thank you very much for that nice introduction. So I'm going to talk more about treatment of peripheral neuropathy, and Dr. Lewis went into this in some detail, but I'll, I think, touch on a number of other items. I think this slide sort of illustrates the challenge that we have and the problems we have in the field. It's very common that patients come in and they bring in a newspaper, like a whole page ad with treatment. So people are nodding. So who here has seen these ads? Everybody. Have any of you been to these? Yes? And you're here today. So obviously it didn't help. And I think the issue is not so much, often what happens is the treatment is not really very well outlined, but there's usually an offer of a free meal. There's a nice juicy steak here on this ad. And the treatments themselves may or may not work, but the problem is that you're sort of pressured into a very expensive treatment that has, at least, dubious benefit. And it's unfortunate I would call this a scam. The reason these scams exist is that one is that many folks have limited access to treatment for neuropathy, and unfortunately, many of the treatments that we have as neurologists are inadequate, so patients are seeking other options. So, they don't have the 11th annual syphilis conference here because we have great treatments for syphilis, and so, you're not coming year after year for your syphilis update. Anyway, from torture to syphilis, okay. So why, what do you mean by treatment? Well, I think Dr. Lewis went into this a little bit. There are interventions that can heal the nerve, and those are relatively limited, but these are expanding. There are interventions that improve function, and then there are interventions that reduce pain. And the focus has been historically on, or up to now, on the pain interventions. One question that comes up is, how reversible is my neuropathy? Can you really heal it? And it is best when the neuropathy, I would say, is relatively recent onset. That's better. Overall, if it's autoimmune, particularly these demyelinating neuropathies, acquired demyelinating neuropathies. And in general, if there's an identifiable cause, that's in your favor. And many of you here probably have an idiopathic neuropathy. The cause is unknown. Is that right? Who here has an idiopathic neuropathy? Okay, about a third at least. The bad news is that there's no panacea, there's no universal treatment that we can give you that will just reverse your neuropathy. So what we try to do is identify an insult to the nerve, and if that could be removed, then the neuropathy at least could be stabilized, and there could be some improvement. And obviously, this is an obvious statement, and this is Captain Obvious from an ad campaign. So here is sort of the challenge for the different sort of categories of neuropathy. I mean, some neuropathies are caused by medical illness, so obviously if you address the underlying medical problem, that will help the neuropathy, but sometimes that's hard to do. If it's a toxin-induced neuropathy, for example, an alcoholic neuropathy or caused by chemotherapy, if you stop that insulting agent, the neuropathy will stabilize and potentially improve. Nutritional deficiency, I would say a relatively common thing that we see are patients who develop neuropathy after weight loss surgery. Those folks are instructed to take vitamins, but may forget to take the vitamins, and then they come in with a neuropathy. If they then resume the vitamins, usually the neuropathy at least stabilizes. For the genetic neuropathies, the ideal thing would be to fix the genetic defect, and this is really not possible, although there are workarounds. Dr. Lewis mentioned spinal muscular atrophy, which is a paralytic type disease, but there are other neuropathies, such as a genetic form of amyloid neuropathy. Anybody here probably nobody here has familial amyloid neuropathy, but there are some very elegant targeted therapies for that particular neuropathy that are here and under development. But again, many of the people that I see in the clinic that come to these meetings have neuropathy of unclear cause, and you're sort of orphans because you don't really have a disease that's causing it, and therefore there really isn't something you could really attack and address, and you feel sort of left alone. Many people have diabetic neuropathy, and still the mainstay approach for addressing this is improving glycemic control, the glucose control. The evidence is better for, the efficacy of this is better if you have the type 1 form of diabetes than the type 2 form, but there's still evidence. The danger is that if you are really tight with your glucose control, you can sort of overshoot, and there's an increased mortality potentially of doing that. So there's sort of a fine balance that needs to be had. Treating lipid disorders and high blood pressure, and particularly using ACE-type drugs for high blood pressure, seem to help this condition. There is sort of a mixed literature on alpha-lipoic acid. I generally do recommend alpha-lipoic acid for neuropathy. I don't know if Dr. Lewis does. Do you? He does, okay. Some organizations do not recommend it, but others do. I know that there's an integrative medicine person speaking to you in the afternoon. I would guess that person is going to go into vitamin therapies. And then there are the immune-mediated neuropathies. So we do have treatments for these. It's important to recognize that the treatments, what they do is remove the inflammatory effect or the autoimmune effect. They don't actually heal the nerves. We rely on the body to heal the nerves. So sometimes patients come in with a fixed neurological deficit, and it seems like the inflammation is long gone, and the patient may request IVIG or plasma exchange, et cetera, and there really isn't a role for that because the inflammation is long gone, and those treatments won't heal the nerves. There's sort of three sort of first-line therapies for the immune-mediated neuropathies. One category are the corticosteroids. Prednisone, these are not like the Barry Bonds build up your muscle strength steroids. If anything, these drugs make you look worse and feel worse. People are attesting to that right now. They can be very effective though, and it's cheap, at least in the short term. Some argue that there are a lot of expenses associated. Well, it's well known that if you take it for long periods of time, all sorts of complications can develop, and some of those carry significant costs. So the picture here just shows a patient with the facial changes that occur with high-dose corticosteroids. It's sort of called a Cushingoid appearance of the face. Plasma exchange. The idea with plasma exchange is sort of intuitively makes sense. You're removing the autoantibodies and other humoral factors that are contributing to the neuropathy. The evil humors are removed from the body. This is done through a large catheter usually, which makes this somewhat difficult treatment at times, although sometimes the treatment can be administered through large veins in the arms, as sort of depicted in this picture on the bottom. But basically, venous blood is taken out of the body and it's passed across a membrane, and the patient's plasma is removed, and then artificial plasma is then instilled, and this has a therapeutic benefit. The problem is you have to keep on doing this to maintain the therapeutic benefit. And then IVIG, which I would say is probably one could argue, the most broadly efficacious therapy for the immune-mediated neuropathies. It's usually well tolerated. These are infusions of immune proteins that are given over 2 to 5 days and repeated monthly or so usually. These therapies are effective. There are side effects, including headache, and people feel kind of sometimes tired. Dr. Lewis mentioned that sometimes, however, some patients feel a lot of energy, particularly after the day after the infusion. They can feel a boost from it. I don't know if I mentioned, but headaches can be a problem. Chills, rashes can be an issue. Rarely things like stroke can happen, but that's very rare. Overall, it's a very well-tolerated therapy, but really only useful for the inflammatory type neuropathies. There are lots of other treatments for immune-mediated neuropathies that I really don't want to get into. I just put them on the slide just to let you know that there are a lot of potions out there that we use to try to treat these neuropathies if the first-line therapies don't work. So then the other treatment has to do with interventions that improve function, and these include canes and walkers. So a cane for a person with neuropathy, it's a very basic intervention, but can be very helpful. There was I mentioned earlier about balance in neuropathy. So in order to have balance, well, it's important, it's helpful to have a type of sensation called proprioception from the lower limbs. And if you don't have that, then you rely on vision in the inner ear. And then, as was said earlier, if your vision is affected because you're in the shower washing your hair or it's dark outside, then balance can be a big problem. But if a person with a neuropathy can place their hand on a piece of furniture that provides that proprioceptive cue, because usually with neuropathy, the proprioceptive pathways in the arm are working relatively well. And a cane also allows that. So just a little bit of a touch using one hand or the other, or using a cane, can make a big difference for folks with neuropathy. Some neuropathies are associated with foot drop, and ankle foot braces can help a lot. There are a variety of different types, some with hinges and some without, and made of different materials. Physical therapy can sometimes help. Tai Chi type exercise and physical therapy-led gait training and balance training can sometimes help. So now we're moving to the pain treatments, and there's this sort of tiny print here because there's a whole bunch of things that have been tried for neuropathic pain relief. And I do think that different providers have sort of a different biases in terms of treatment, because what you're exposed to in your training and in your professional groups, I would say there's a bias that we all have in thinking about these agents, because we tend to prescribe what we're most familiar to or with. So breaking them down, there are two basic categories: pharmacologic therapy and non-pharmacologic therapy. And now the font is a little bit bigger for you to see these. So the pharmacologic therapies, the big categories are anticonvulsant therapies, also antiarrhythmic therapies. The idea is that this sort of reduces rapid firing of the nerve, which has a pain relieving property. Certain antidepressants seem to help. In general, these work more on the central nervous system, but with at least one category, there's also a peripheral effect on the nerve itself. Narcotic or opioid therapies, and then topical therapies. And, marijuana is kind of a big thing. Cannabinoids have been studied, and a variety of other therapies that are on the slide there. And we already mentioned alpha-lipoic acid. Non-pharmacologic therapies, there are a whole bunch here. Infrared therapy, shoe magnets, exercise, acupuncture, electrical stimulation, spinal cord stimulation, biofeedback, behavioral therapy, surgical decompression, and intrathecal baclofen. All of these items were actually from a paper on a guideline that came out from one of the major neurology organizations. And basically a panel of folks looked at lots of different treatments, and they made a judgment as to whether or not the evidence supports recommending them. And these folks concluded that Lyrica or pregabalin, which is in the top left on the slide, had sort of the highest level of evidence of efficacy. The other recommended therapies, and one would imagine, this is for diabetic neuropathy, but these treatments would presumably help other types of neuropathic pain. The other recommended therapies include gabapentin, valproic acid, that's an anticonvulsant, venlafaxine, duloxetine, those are antidepressants, amitriptyline, antidepressant, dextromethorphan, which I'll talk about a little bit later, morphine, tramadol, oxycodone. So oxycodone is a narcotic drug, capsaicin, which is the chili pepper stuff, topical, isosorbide dinitrate spray, which is sort of like nitroglycerin that's used for the heart. The spray is actually not available in the U.S. And then, anybody have isosorbide dinitrate spray? No, okay. And then electrical stimulation, I was sort of surprised they put this on the list, but they did. The general approach when we prescribe these drugs, I would say, is that we use one of the so-called first-line therapies. If the pain is restricted to a small area, and particularly if the patient has lots of hypersensitivity in the feet, a topical therapy is usually helpful, like lidocaine, a patch, or cream. If that first-line therapy works sort of okay, but not perfectly, often a drug from another category is used with that therapy. And the hope is that if you use sort of moderate doses of multiple drugs, that you may have a good therapeutic benefit without too many side effects. And we try to tailor the medications to the patient, so we sort of think about what medical problems the patient has and what other medications the patient takes, and you're trying to minimize side effects. If there's no relief at all from the first drug, then you go to a different category and start there. There are a lot of challenges in using these drugs. Often the drugs are prescribed at too low of a dose and never increased to a therapeutic dose. Also, the drugs are sometimes started at too high of a dose, and the patient has intolerable side effects, and it's thrown into the waste bin, and the patient has a very negative feeling about that drug when it could have maybe have worked if the drug was started at a low dose and slowly worked up. Convenience is a major consideration in thinking about these drugs, and certainly if a patient is taking many different drugs, adding another drug increases the risk of intolerable side effects. So topical therapies, lidocaine is used both in a patch and cream form. There are also compounded preparations that have a variety of things in them. My personal feeling is that the main therapeutic benefits of this compounded preparation are the anesthetic component of it, and that's sort of my own opinion regarding that. Capsaicin, which is available as sort of a topical cream or fluid, but also now is available as a high potency patch. Anybody here take or use capsaicin? Okay, one person. I think a lot of people try it, but relatively few stick with it. I don't know for sure why that is, but it's not many people are on it over the long term, it seems to me. So the idea here with these therapies is you sort of desensitize the nerve and then you reduce the pain signals. There are over-the-counter preparations that have lidocaine, actually at reasonable concentrations, like 4 or 5%. There's this preparation called Recticare, which is designed for hemorrhoid use, but it can be applied to the feet. If you use it for hemorrhoids, you may want to get a separate tube for your feet, I would say. Anyway. But this seems to work well. The cream seems to penetrate well for this particular product. So some patients have had good favorable responses to this. It's actually $20. I think that the Zero got cut off, but it's not quite that cheap. But it's still relatively cheap. It's still like sometimes around the copay level of prescribed ointments. And some of the prescription ointments don't penetrate quite as well. There's Icy Hot with lidocaine, which has a menthol product, but also lidocaine. And some of my patients seem to respond quite well to that. The antidepressants, there are different categories or types of antidepressants. The main therapeutic categories are the tricyclic drugs, which are these ancient drugs that have been around forever. And they function at, that NE is norepinephrine on the slide, and they also block sodium channels. They work very well, but they have some side effects which become major issues when prescribing them. And then there are the serotonin norepinephrine reuptake inhibitors. In this category, duloxetine or Cymbalta and venlafaxine. The other category, the SSRI, which includes, this is a selective serotonin drug, this category includes things like Prozac and Celexa. These have less evidence of efficacy for neuropathic pain. For the tricyclic drugs, there are a number of them. This slide doesn't have all of them. The two that I tend to prescribe are nortriptyline and amitriptyline. And if a patient has sort of out of control pain and they can't sleep and are very miserable, I tend to use amitriptyline partly to use the side effect of this drug to the benefit of the patient, because it is one of the more sedating of or maybe the most sedating of the tricyclic drugs. But if a patient can get to sleep all right, then I usually do nortriptyline, which has an overall better side effect profile. So these drugs can be sedating, can make people feel sort of foggy-headed, dry mouth. There's sexual side effects, weight gain are problems. If you take a huge amount, it would kill you, which is not good, because of the effects on the heart. Anybody here on the tricyclic drugs? Okay, you're on amitriptyline, great. Is it working for you?
Yeah, I take Celexa.
Oh, you take Celexa too, okay. Anticonvulsants, so there are a lot in this category. The drugs that are, I would say that the first line drugs are at the top left here, gabapentin and pregabalin, Neurontin or Lyrica. But there are many different options here. Lyrica is a controlled substance. It has an FDA indication for diabetic neuropathy. It's used for lots of other things off-label, restless leg syndrome, migraine, alcohol withdrawal, lots of things. And it binds to a subunit in a calcium channel, and its effects are mainly in the central nervous system. It's much more potent than gabapentin, which is the older drug. Lyrica is just available as the brand name product. Weight gain is a problem. Edema is an issue. Patients can see double at high doses and have poor balance, which is obviously a problem because the balance is already an issue with neuropathy patients. But this is still widely used and effective. Gabapentin is a similar compound, but older, and it's easier to prescribe because it's not a scheduled substance, so it's easier to give your patient refills. Also, the insurance company doesn't put up a fight. So I would say that I usually prescribe gabapentin first for patients. Large doses need to be used often in order to have a good therapeutic benefit. And then there are some other anticonvulsants, carbamazepine and trileptal are drugs that are particularly effective for a painful condition in the head and face called trigeminal neuralgia, where the patient has electric shock sensations in the face with things like wind and light touch. These can be used for sort of the more garden variety neuropathy affecting the feet, but maybe are not the first line therapies. Then there are narcotic therapies or opioid therapies. These are in the news a lot, the opioid epidemic. And there is, I think opioids have always had, or sort of been complex drugs from sort of a psychosocial, societal standpoint. I think in prescribing these drugs, there's sometimes sort of a stigma of doctors who prescribe a lot of these drugs and also patients who take them. So as a society, we have sort of complex feelings about these drugs. They are, for chronic pain in general, they're considered sort of the gold standard therapy. The use of them, specifically for neuropathic pain, well, when I was a medical student, I was told by many of my mentors that these drugs don't work for neuropathic pain. But it has been shown that they do work for neuropathic pain, and they're quite effective. But they're not perfect, and a lot of trials that have had an arm where patients take narcotic therapies, there's usually a fairly large dropout rate in those who receive these drugs in clinical trials. So patients often don't feel great on them. There's issues of constipation and also, of course, tolerance and dependence that limit their use. I think these drugs are helpful. Like a particular situation in which I think these drugs can be helpful is the occasional patient that has pain in the feet, but also at night a lot of restlessness. So they will say that basically a restless leg syndrome, where they feel like a buildup of sensation in their feet at night, and they get out of bed and walk around, and then the sensation goes away, and they go back into bed, and then it comes back. So if a patient has a restless leg syndrome from neuropathy, these drugs, I think, can be quite helpful for that situation, and also for patients with very refractory pain. Tramadol is a drug that shares some characteristics with the opioids, but it's its own kind of category. It also works at norepinephrine receptors, and it's an effective agent for pain and for neuropathic pain as well. It's another thing to consider. It's in its own sort of category. I think before there was a slide maybe on Perry Shea's talk about how how the information goes when you have neuropathy, or just in general just the physiology of sensation. So you have your peripheral nerve that carries signals to the spinal cord, and then the signals go up the spinal cord into the brain. These drugs, well, the topical anesthetics and the local anesthetics work, as you would imagine, peripherally, but some other certain anticonvulsants and also the tricyclic drugs have an effect on the nerve itself, whereas the opioids and the SNRI drugs have more of an effect on the central nervous system. There's a pain pathway that in which the information goes up to the brain, but there's also a pathway from the brain down into the spinal cord that tends to gate pain information as well. And these drugs work on those pathways too. So on the list of recommended drugs was dextromethorphan, which is basically Robitussin. Has anybody tried dextromethorphan for neuropathic pain? Dr. Lewis, have you ever recommended it? So doses around 400 milligrams a day were shown to be effective. And that, if you were to take Robitussin, that would be like a half a bottle a day of Robitussin. And that it does induce sort of a dissociative state. It binds with NMDA receptors in the brain. Anyway, I haven't prescribed much of this, but in preparing for this talk, I was sort of intrigued by it. And in the United States, you can only get this you can get Robitussin over the counter, but there is a prescription syrup you can try, you can prescribe, and I think I may try it in my patients. Not myself. May try it myself too, I don't know. Medical cannabis, so this is a map that shows the legal status of cannabis in various parts of the world. So blue is, I think that my blue box turned into a brown box, but basically dark blue is legal or essentially legal, so sort of the more Western and liberal parts of the world, it's more legal in general, I would say. It's still a Schedule I substance, so it's from the DEA standpoint, it's a very hazardous substance. And as you know, the federal law outlaws its use, which makes sort of our current situation with it being legal in states complicated. And as you know, it's available in a variety of forms, including tinctures, there are edible forms and vaporized smoked forms. And The benefits, the purported benefits are many, including pain relief, improved nutrition, it's thought to reduce nausea and vomiting in cancer patients. It's been studied in neuropathy in my hometown. This is now a fairly old study, but about 10 years ago, there was a study at UCSF, or actually at the General Hospital in San Francisco by Don Abrams and his colleagues, where they brought patients into the hospital and they had marijuana cigarettes, and in some of the cigarettes they leached out all the active ingredients. So they had active marijuana and then the sort of faux cigarettes, and they had to make sure that the smoke got out of the hospital and not into the other patient rooms. But anyway, the patients who took it, they reported, improved pain scores. Now, the people who were in the study were experienced marijuana users, so you could argue that it wasn't really a blinded study because they could probably tell that they're getting high. But anyway, there's this and other literature that supports its use. I think different doctors I think doctors are all over the map in terms of how liberal they are in filling out the physician statements to get the card. I have been fairly liberal in doing it. I have a colleague that doesn't ever fill them out. It's all becoming a moot point because recreational marijuana is going to be available soon, but it's another option. I do have patients that feel that it's been the best therapy that they've ever tried. Anybody here use it and like it? Useful? Okay. They're nodding sheepishly. Okay. Don't worry. Another thing that was recommended in that outline, and I just have a couple more slides here, was electrical stimulation. And I did notice that there was a very sophisticated electrical stimulator out in the waiting area out there called a scrambler unit, which is a complex device that I think varies the frequency of stimulation. And it's sort of basically one of the things, like at the top here, the frequency modulated electromagnetic neural stimulation or something similar to that. But there are a variety of stimulators, and the literature is very mixed here. There are some studies that have been positive, many negative. But at least when the panel made the recommendations for the diabetic neuropathy, they did include it as one of the therapies that they recommended. I don't have tons of personal experience with these stimulators, but I would say that I have some patients that have used it and continue to use it. As a matter of fact, I have one patient that he has pads on his feet. He has these pads on his feet all the time. He's threaded wires up his pant legs and has the stimulators in his pockets, and he uses it, and he gets a lot of pain relief from it. The devices, you can get sort of the basic devices very cheaply. So this particular device on Amazon is $31. So I think if, I kind of poo-pooed the treatments at the very beginning of, the whole newspaper thing with the free steak. I mean, those therapies, because the reason I denigrated it is because it's very expensive and it may not work. Whereas this is $30 and may not work, but it could work. And I think, it may be worth thinking about if other things are not working well. Certainly there's no side effects really from this type of therapy. At the bottom of the slide, I've just put some of the parameters that were used in one positive trial. And I could share that with you after the lecture if you're interested in trying one of these things. And then there are these very sophisticated devices that are out in the hallway, and those therapies are administered by physicians or other providers. But you can buy basic units that you can take home. So again, sort of the standard Western medicine approach here is if you're going to use an oral agent, we first pick one of the first-line therapies, and if it doesn't work at all, we go to a different first-line therapy. If it works sort of okay, we add another therapy to it usually. If there's a lot of hypersensitivity in the feet, topical therapies are tried. There are a number of those are available. And this is just what I said. So finally, my final points. Many of the treatments that we have are really aimed at pain relief, and the treatments that really fix the neuropathy are frustratingly few. And then those of you with idiopathic neuropathies are kind of orphans in the medical system currently, I would say. Navigating these treatments is difficult, partly because each provider has different biases in terms of their feelings about treatment. I would be wary about very expensive treatments for your peripheral neuropathy. But on the other hand, it's helpful if you and your doctor are open to trying different things that are not super expensive or super dangerous. And that's it. Thanks a lot for your attention.